I'm just going to introduce all our panelists, and then I'm going to hand it over to Dan to introduce the patient case. So I'm super excited because I did a little digging on our panelists, and everyone has really unique backgrounds that I think are going to create a cohesive, integrated conversation on critical care from kind of a couple different aspects. So we're joined by Dr. Nick Johnson from Seattle, and he serves at the University of Washington as an assistant professor in the Department of Emergency Medicine, as well as an assistant professor in the Division of Pulmonary, Critical Care, and Sleep Medicine. Dr. Johnson is an associate program director at the Critical Care Medicine Fellowship there and practices in the ED, MICU, and Neurocritical Care Service at Harborview Medical Center. His research interests include cardiac arrest, mechanical ventilation, ARDS, sepsis, and ECLS. He's also part of this really cool project that I didn't know about until I did some digging called EMCCM, which connects emergency medicine physicians and critical care physicians all over the US in a network with the American College of Emergency Physicians, the American Academy of Emergency Medicine, as well as the Society for Academic Emergency Medicine and the Society for Critical Care. So welcome, Dr. Johnson. Next on our panel, we have Dr. Julie Veith. Dr. Veith is a fellow of the American Academy of Emergency Medicine and the American Academy of Emergency Physicians. She serves as the director of the ED at the Canton Potsdam Hospital, which is a level 3 trauma center in the St. Lawrence Health System in New York. Dr. Veith also serves as the AAEM's Emergency Medicine Workforce Committee Vice Chair and has given back to academic medicine and medical education as an educator for resident simulations at the George Washington Hospital. I'm excited to hear your perspective, Dr. Veith, particularly because I realized that you had a background in nursing and went and got your nursing degree first. And so to see that kind of that overlay and different points in that critical care spectrum from the nursing aspect as well as the physician aspect, I think will be really interesting. So also, I'd like to welcome Dr. Matt Roginski, who joins us tonight. He's an assistant professor of medicine at Dartmouth. I'm not going to pronounce this right, am I? Geisel. I have to look up the pronunciation. Geisel, okay. School of Medicine, and the assistant medical director of the Dartmouth Hitchcock Advanced Response Team, as well as the medical director of the Advanced Practice Provider Critical Care Residency. So Dr. Roginski's clinical interests also include critical care transport, mechanical ventilation, and critical care ultrasound. And his publications are in hypoxia, ARDS, and EMS intubation. So I suspect he'll have a couple things to say tonight, so I look forward to that. And last but not least, we're joined by Dr. Michael Sterwald. Dr. Sterwald is passionate about, Dr. Sterwald is passionate about pre-hospital and retrieval medicine, as well as emergency area management, and is the director of the Emergency Area Management Program and the medical director of the University of Wisconsin Med Flight Program. Additionally, Dr. Sterwald serves as the associate medical director of the Difficult Airway course, which is an EMS education program, and is an assistant professor at the University of Wisconsin School of Medicine and Public Health in Madison. I'm super interested to hear what you have to say, Dr. Sterwald, because I did EMT work before med school. So I'm interested, again, to see that intersection of EMS and critical care from the physician's perspective. So with that, I'd like to turn over to Dan to introduce the patient case for tonight.
Sure. Well, I think before I do that, and not to delay anything further, but Jocelyn, I don't think you've introduced yourself.
Sorry, not very interesting. I just finished my first year of med school in Yakima, and I'm very interested in EM, as well as potentially doing an EM-IM fellowship. So I have a couple years to go in med school, but I'm super excited to be part of this panel and hear such an important topic, especially in the midst of COVID. So super excited. Thank you, Dan.
Yeah, and my name is Dan. I'm a fourth year at the University of Queensland Oshner Medical School down here in New Orleans, where it just hit 90 degrees and boys, it's hot. So I'm going to share my screen, and I have a patient vignette that all of our presenters should have had a chance to see, but just for the folks playing at home, this is a 68-year-old gentleman with diabetes and hypertension diagnosed and seen in your community emergency department 3 days ago. At that time, had normal air oxygen saturation, normal labs, ambulatory oxygen saturation of 93%. He was discharged home with a home pulse oximeter and return precautions, and he returns today via EMS for oxygen saturations that have been worsening overnight and are now in the upper 70s, more fatigued and dyspnea with exertion, afebrile, almost tachycardic, and more importantly, an O2 of 82%. So The lung sounds are decreased, the soft abdomen, the opening edema. And the question for our panelists that we really wanted to suss out was, now that the labs are obtained and you've started the patient on a non-rebreather, the hospital's full, and the decision has been made to transport this patient to a tertiary care center. And you get off the phone and you find that the patient is still desaturating, and there'll be a 4-hour delay getting this patient to the referral center. And their oxygen saturation right now in non-rebreather is 86%. So, Dr. Johnson, why don't we put you in the hot seat first? What's your next step?
First of all, I'm lucky that I'm usually on the receiving end of these phone calls and not the one making them. I have much respect for folks who don't have like Ecmo at their fingertips like we do at my hospital. So, I think the first thing I would think about is, what do we need to do locally to get this patient a bit more stable for transport? And then how can we stabilize this patient for the transport itself? And first of all, I think, looking at the patient and getting a sense of whether this is hypoxemia with high work of breathing or hypoxemia alone. And I'd also like to get a sense of what their ventilation was. So, the ICU doctor in me would probably want a blood gas up front, not to make a decision about intubation, but also to get a sense of whether this is purely acute hypoxemic respiratory failure, or this is mixed respiratory failure, because there might be a different treatment pathway for either of those patients. And then I think, if this patient were in my hospital, he would warrant a trial of high flow nasal cannula. That's our preferred device based on the Florali trial, comparing high flow non-invasive and other oxygen delivery devices in patients with hypoxemic respiratory failure. And the key for me is it's a trial. This is a guy who, I have all my airway stuff nearby. We're ready to go if he starts to deteriorate, but I would attempt a less invasive approach, monitoring him closely and keeping an eye on trajectory over the next 30 to 40 minutes. And over that time period would make a decision about whether that's working or whether we need to move to endotracheal intubation. And I think if this is pure hypoxemic respiratory failure, for me, there's less of a role for non-invasive ventilation or CPAP. But that might be a good option for transport if we can't oxygenate him, and obviously can't do high flow nasal cannula on the back of an aircraft or an ambulance easily.
Wonderful, thank you. Since we mentioned aircraft, Dr. Sterwald, do you mind if I go to you next?
Sure. Hi everybody. My name's Mike. Nice to meet y'all if I haven't met you before. This is actually a pretty routine instance for me, being in a case like this, and arriving to the patient's bedside is something I do probably once every 2 weeks, get a case like this. So I agree with Nick completely that all of those considerations are the thought bubble. From a transport perspective, though, I will tell you, and most of you know, that a transport program in the United States, especially if it's a rotor wing transport program, is incredibly variable. It might be a spectrum like this in terms of what the capabilities are. It might be a very fresh nurse paramedic crew with a very tiny helicopter with not a ton of equipment, to a crew with tons of experience with a huge helicopter with ability to do all kinds of different airway and ventilatory maneuvers, including high flow nasal cannula, including non-invasive, including even if need be, cannulating the patient where they are and putting them on Ecmo and bringing them back. So the options with respect to what you do in transport is really a function of what the team's capability are that are in your area. I'm in a kind of a unique role where our transport program has physicians as part of the air medical crew. I'm an emergency physician, not formally critical care trained. So when I get to the bedside, my mindset is much like I am in the emergency department, where it's, what do we need to do to stabilize this person to get them to the tertiary center. From a purely respiratory failure perspective, I have taken the approach of non-invasive. I have taken the approach of endotracheal intubation. I'll I guess stop there, because I think more of the session will be talking about branch points in your algorithm. But those are kind of the immediate thoughts.
Yeah, thank you for that, Dr. Sterwald. Yeah, we'll definitely be getting into that in the coming questions. Dr. Veith, I wanted to take a step back and talk to you a little bit. At your shop, what is your next step, and what are your considerations for the patient vignette?
Sure. So by background, I work in a rural setting. My nearest tertiary care center is almost, well, 2.5 hours by ground. 2 3/4 if we go to Burlington, where I know Skylar is watching, where I send him patients. And so many questions. So for me, the questions are, what are my transport options? Because it might not be flight, and traditionally flight for us is actually fixed wing, not helicopter. And that's for weather reasons. My next question is, do I even have flight? So if not, they have to go by ground and my crews aren't as good. My next question is weather. I mean, these are literally some of the more logistical questions that then help me know, how long is this patient staying in my emergency department? And how long am I actually going to be, quote, stabilizing them versus actually just treating them? So assuming best case scenario and everything's going to work perfectly, and I have a flight crew and they're going to be able to get out. My flight crew can't do high flow nasal cannula, but they can do BiPAP. And again, I'm looking at the patient and sort of getting some of the same numbers that everybody has already talked about. But I'm then doing the phone a friend and being like, hey, what do you guys want to do? Do you want us to intubate early, or do you want a trial of BiPAP? And the last thing I want, though, is that my flight crew to be having to intubate en route. And so that definitely comes into the conversation. But otherwise, I would definitely consider, if there was the option for BiPAP, I would consider that, and high flow maybe until flight got there. But I also want to trial the patient on BiPAP before my flight team gets there to know if they're going to tolerate it or not.
Yeah, wow. I hadn't even considered the weather considerations, but upstate New York, of course. Dr. Roginski, you, I think if I recall, would skip BiPAP. Is that correct?
Yeah, and it depends on I think it depends where you work. And a few years ago, I used to moonlight in a similar 6 ED bed ED where it was me and 2 nurses, and you're like, oh, we have to set all this up ourselves, and what are the transport considerations? And now I have the nice warm blanket of a tertiary care center around me. And when Nick was referencing the Florali trial, for patients that are hypoxemic respiratory failure without hypercarbia, with not from pulmonary edema, my algorithm over the last kind of year from being in the ED and the ICU is see where they settle on see where they settle on high flow, not predominantly using CPAP or BiPAP, and then kind of watch their trajectory. And this is one of the things that I feel lucky I'm able to do when they get admitted to my ICU. I have hours and equipment and backup to watch that trajectory, the work of breathing, how much oxygen they're requiring, how much flow they're requiring to time that intubation decision. But we've kind of gotten to I don't want to speak for all my partners in the ED or the MICU, but we've kind of shared the high flow to intubation algorithm and see where the patient settles out.
And what's oh, sorry, Andrew, go ahead.
Yeah, so I was going to play peanut gallery. So I didn't in the beginning say who I am, but I'm Andrew. I'm a has-been on the committee or the council, and my role is to be peanut gallery. So I want to hit you guys with we talked about, for example, Nick, you wanted the gas, as a good intensivist always does, to decide, on the intubation on the EM side. But our practice in the ICU, we have a lot more data points, right? By the time we're being called in the ICU, you've already seen the trajectory of the respiratory rate changing, the SATs changing, the work of breathing, et cetera. So I want to ask folks what the difference is. So we're talking about the transport, and on the ICU side, you're thinking of what their transition is. What is the difference in your intubation decision when you're practicing in the ED and get maybe 2 total decision points over the course of an hour, say, versus when you're making that decision in the ICU? What variables are you looking at? Are they the same in the ED setting as the ICU setting when you're looking for that transport decision? Because some of us, for example, I work in a non-academic ICU. I have to ship some folks from the ICU at my hospital to a tertiary care hospital. My decision points are certainly very different in the ICU than the ED. So I'm going to flip it back to you. What is the difference in your practice?
think I look at the same three things, but my thresholds may be a little bit different. I think I look at gas exchange, worker breathing, and trajectory in either setting. There are going to be those patients that come into the ED and you know when you walk in the room that they're going to be intubated in the next few minutes. Like there's just worker breathing wise, they look terrible, and there's going to be no rescuing them with less invasive devices. And those patients exist in the ICU, or they exist on the floors, and you meet them shortly before they come to the ICU. But generally, we have a little bit more data and a little bit of a better sense of trajectory in ICU patients. But I still use the same three factors. I just have a little bit less information in the ED, or when I'm talking to an outside referring hospital about the trajectory piece. But if worker breathing is low and the patient is able to be supported with a less invasive device, then either way, you've got some time, and that's where you establish the trajectory, and that can be done in the ED or in the ICU.
Dr. Roginski, you want to go next?
Yeah, I kind of feel this countdown clock, and where I'm willing to watch and wait. People get a little bit more hypoxic in the ED, but if there's any question in my mind, if I'm accepting someone from a referring hospital, or they're in my ED and say it's going to be a trial for an hour and I'm still on the fence, I feel where I've had really a lot of regrets when I've been working in the ICU has been delaying intubation too much, either for things are on that slow down slope and then they crater when you intubate them, or we get them set on high flow and then things get a little worse, or they're on BiPAP and they're on BiPAP for too long. And I haven't had too many bad regrets intubating someone and then figuring out, this doesn't look too bad, flip into pressure support, work towards extubation. So I think my timeline is just a little bit more compressed, where we'll intubate and recommend it a little earlier, so we're not putting people in the situation where they're on 60 liters, 90% high flow, and now things are looking tenuous, because that's not going to be a good transition.
Dr. Veith, what about you? What's the dynamic factors that you're looking for?
Yeah, I mean, I think in situations like this, you're darned if you do, darned if you don't. You're going to be criticized from the little podunk hospital, no matter what you do. Having said that, it's often a conversation with whoever we're sending to, like, what do you want to do here? And obviously they can't always see our patients if there's no telehealth communication. And then sometimes it's a conversation with we use LifeNet with their crew as well. What are you guys comfortable with? Let's do this together, and let's either intubate early or not. But in patients like this, if I at all think that there's a chance that this patient is going to need to be intubated before they make it to the ICU, then I'm intubating them in my ED. And so that may mean a little earlier than you would watch them. But again, I don't want them to have to be intubated in the back of an airplane or helicopter with less resources and a moving aircraft. So we would definitely do it a little bit earlier.
And Dr. Sterwald, any final thoughts about decision points in the ED versus the ICU? I know you're an ED doc primarily.
Yeah, not beyond what wiser minds have already said, but I think if I'm in a small hospital, like the one being described at the bedside with an emergency medicine colleague, and usually the patient is, if the patient's on a non-rebreather mask and nasal cannula or something like that, they're usually got work of breathing that isn't profound, and their SATs are usually stable-ish to the point where we're going to leave with that person on that mode of ventilatory support, or at least oxygenation support. If I arrive and that person is on bi-level already or other non-invasive ventilation, then I think the most important of NICS criteria in terms of like trying to figure out what the anticipated clinical course is, at least the most dramatic one is the work of breathing. And if the person is relatively chill and relatively stable, then we usually end up going with the patient on non-invasive. We're fortunate to have ED docs on our helicopters, so if we do have to intubate on the way in relatively big helicopters, that's cool. If we can do it before we leave, we obviously want to. The other thing that goes into my mind just a smidge when especially up here in Wisconsin. If we arrive, and I think that the course of airway management is going to be better with a couple of hands, as opposed to a very tiny ED someplace, and they're stable-ish on the bi-level. Will oftentimes go so that when that person does get their endotracheal intubation, it can be done at the center, and you're almost pre-oxygenating and optimizing them on the way. That's obviously a risk-benefit calculation because, as Julie said, if you do encounter a moment of truth on the way, then that's no bueno. So yeah, I guess that's my final. I forget who it was, but yeah, you're damned if you do, damned if you don't, and you can be screwed either way.
I like that. Thank you.
So I think the next question that I'd love to hear, Dr. Veith, maybe I'd love to hear your feedback on first, just because I think you kind of started to talk about this, is how have our decision-making processes gotten back to where we were pre-COVID with ARDS and pneumonia, and what factors do we consider? So I know you talked about certain factors that we consider regardless wherever we are, but I'd be interested to see how some of those factors have changed pre and post pneumonia. So not weather, other factors, but what is your perspective on that?
So, I mean, specific to COVID, are you talking about?
So decision-making with ARDS and pneumonia, how has it changed from pre-COVID times to now in your perspective?
Oh, okay.
Mm-hmm.
Yeah, I mean, I think so pre-COVID, I would say probably all the same things because I'm still taking into account this transport time. For me, the most dangerous time for my patient is the time they leave my ED until the time they land either in the next ED or in the ICU. And even with flight, that's usually door to door, a minimum of an hour. And that's, everything running beautifully. And so I'm again still just anticipating, are they going to decompensate on the way there? And I would say in that regard, nothing has changed. Like, we're still having those conversations. I will say though, at the beginning of COVID, A, pre-vaccine, B, when we didn't know BiPAP, CPAP, intubate, not, there are all those questions. There was definitely more conversation with the intensivist on the other end because there was so much more planning that had to go into it with the logistical side of things and who are we going to expose. And for a while, we couldn't do BiPAP or CPAP on the flight because the pilots weren't protected until we figured out how to do that with the aircraft, and they figured that out. So, something that I'd never even thought of. Now, luckily, we're long past that. But in terms of pre-COVID and now, I have the same decision points still.
Okay, and how about, thank you, Dr. Veith. Dr. Roginski, I know you work in a kind of less rural, larger environment. How about for you? Has that changed, or has maybe kind of the approach of your shop changed? I know before you were kind of wanting to speak for yourself, but have you seen those practices change either in your own practice or for physicians around you?
I think our ED at the academic center I think we're back where we used to be before, and now I think all of our docs are comfortable with starting high flow and at least initiating that. I do worry about the initial start where we're in the very early days of intubate early and going from nasal cannula to intubation was wrong, and then the worry that I still hear in a lot of our referring places of the happy hypoxic and not intubating when, at least, and again, all in hindsight, because I'm in this warm tertiary care center blanket of, well, we should definitely intubate this patient. So I think I've tracked back to where I was before COVID, and really kind of come back to what the paradigm Nick kind of started with, and if the patient's really hypoxic and working to breathe, just because it's COVID, not realizing that needs a tube and to be put in lung protected ventilation.
Thank you. Yeah, that makes sense. I think so. To follow up, I'd be interested. I guess I'll bug Dr. Johnson for this one. Do you feel now kind of we can't really even say post-COVID, but now at this stage where we are with COVID, do you feel that you're more permissive with hypoxemia for those standard pneumonia cases with ARDS? Or how has your maybe barometer on some of that changed or stayed the same, and why?
No, I agree completely with Matt. I feel like we saw the pendulum swing in two very unhealthy directions. We also went through the early intubation for anyone on more than 6 liters, mainly to protect staff, and we didn't know what we were doing, and we were hearing a lot of anecdotes, and that we did that for a few weeks, and then decided that wasn't a good idea. And then there were all these other anecdotes on the far other extreme of waiting until patients had prolonged severe hypoxemia to intubate, and then they would, not surprisingly, crash after they got intubated. And there were people out there attributing that crash to mechanical ventilation itself, when really it was probably the delay of mechanical ventilation that contributed to some of that. And we also, I think, have landed kind of squarely back where we were. We took care of a lot of immunocompromised patients with bad viral pneumonias in the past and saw a lot of hypoxemia and bad ARDS. And we manage these patients the same way. If they can tolerate high flow nasal cannula as our workhorse device from a work of breathing perspective and do okay as far as trajectory, and we can support them, we'll ride with that. But if not, we'll intubate them and use pretty standard ARDS management. And we haven't really changed that approach all that much. And I think it's working okay. I think our outcomes are as good as other centers. And I don't feel like we have to do anything particularly differently or fancy other than maybe giving patients steroids when we weren't giving a lot of steroids before.
And just to be clear, Nate, you're talking about non-COVID patients, right?
Yeah, we manage our COVID ARDS patients pretty similarly to our non-COVID ARDS patients.
So I guess in that vein, I'd be interested to hear, I'll move on to Dr. Sterwald. I won't make you speak too long, Dr. Johnson. But I'd be interested to hear, kind of in that same vein, then are you skipping BiPAP for other conditions? Like I've heard, like you all have mentioned that you're skipping with COVID and are using high flow nasal cannula more often than you were before COVID?
Oh, was that for me? I'm sorry.
Yes, sorry.
No, in our shop, non-invasive is probably the workhorse for adults as opposed to high flow nasal cannula. So no, we're still using quite a bit of non-invasive, whether it's CPAP or bi-level, both in our emergency department and or our transport setting. To expand on what I said earlier, we can do high flow nasal cannula on the aircraft, but the problem is that when you're talking about for adults, you go through a massive amount of oxygen, so it's not feasible to do that until you're talking about like really short transport time. So I actually don't do that much. As a quick aside, just because it's one of the more interesting things about COVID for me in terms of what changed in the transport environment. Like Matt can probably speak to this too, but before COVID, and this kind of goes along to what Julie was saying earlier, but before COVID, if you were truly on airborne precautions, you pretty much didn't get into a helicopter. There are very few transport teams out there that would transport somebody in a routine way if you were in any kind of airborne and or true droplet and or true contact precaution. So our industry kind of figured this out on the fly, no pun intended, and we're able to start to transport more patients because of it, as was sort of alluded to earlier. So at the very beginning, we were transporting anyone who had any suspicion of COVID in bunny suits, and they had to be intubated. And then as time went on and we realized that the PPE works and the research caught up, then that became much less stringent to where we routinely fly patients on non-invasive who are COVID positive, et cetera. So that has actually fundamentally kind of changed a part of our specialty, which is very interesting.
Yeah, thank you, Dr. Sterwald. I was thinking about that as like previous answers were coming in and sort of as the early pandemic was unfolding, there was sort of this rapid shift in how patients were approached. And it never even occurred to me that the transit and transport might also need to adapt at the same pace. So let me actually continue asking you questions, because when we think about early pandemic versus now, we're much more comfortable transferring patients that early in the pandemic we really wouldn't have. What have you learned, especially in transit, about transferring the kind of tenuous patients, the ones that you're like, gee, I really want to watch this one closely? What have you learned to look for? What have you learned to say no to, I guess, or to say yes to?
That's a great question. We say no to very little. So usually if someone has called us, it's because this patient is better served someplace else. And that's why critical care transport exists, is so that people that can get you from setting A to setting B safely are an option. I guess COVID has dramatically increased the number of patients that I've personally flown on maximal ventilator settings, because usually you don't stay forever in a day at an uber rural hospital when you're approaching maximal ventilator settings, maybe in different environments than mine. It's certainly increased my personal N of patients on PEEP of 15, PEEP of 20 in the helicopter. So that short answer to your question, I guess.
Well, good, because I have a bit of a follow-up then, because I know that proning is a thing that we can do in a non-moving hospital. Is that something you guys consider in an aircraft?
Yeah, for sure. Yeah, so you can prone somebody in a helicopter. That doesn't mean it's a good idea, and you should ask Roginski what he thinks about that. You can certainly prone somebody in a ambulance and helicopter and airplane, depending on the configuration. It is, I don't believe there's much research other than case reports on that yet. The safety profile from just, I wouldn't think it was unsafe or particularly challenging to do. But you certainly can do it. The option we have is we have a team set up to go cannulate people onto ECMO at small hospitals. So the decision point for us is like when they're needing to be proned, is like that's when that team gets involved. So we tend to do that as opposed to like fly them prone, but you can do it for sure.
Okay. Well, Dr. Roginski, since you got name drop, I guess you're going next in here.
I have a mild amount of dyspepsia when we start talking about proning and flying. That this has been a big discussion point at our program, and trying to have one coherent plan. And we've done it a few times, and I'm still in the I recommend against it for all the logistical considerations. And I think of proning as this is something we're doing for 16 hours to, redistribute the ventilation and perfusion, and not something that we're doing in a rescue situation. That if we're in that rescue critical hypoxemia, I think this is where we go for ECMO cannulation. And usually it's not emergency departments that are pushing proning. That the people that are doing the self proning are usually not the ones who are taking on, how many crew calls, and we're like, well, the ventilator PEEP goes to 20. And we can't go any higher. But the proning is something we have to look into when we have community ICUs that have proning. And do we send the aircraft to try to prone? Do we bring a canister of nitric oxide, inhaled epoprostenol? How do we get that patient transported to the ECMO center? Because we don't have, we're not sending ECMO teams out in the field. We're sending our aircraft out to bring them back to us. So we prone a lot of people in our ICU now, and whereas it used to be having to call the team and get it ready and prep everyone, now it's like, okay, it's 3:30, let's go. And person gets a burrito rolled, 6 people, flip them, done, out. But with 2 people, an aircraft, not padding, we've had a couple pressure injury, eye injuries, tube displacement issues, and have tried to advocate against it. But that's not saying there's a right or a wrong. I think we're just seeing the evolution as COVID's come and gone, and we've been pushed more into these situations of, well, the FiO2 is at 100%, the PEEP's at 20, we're in 5.5, 6 cc's per kilo, and we're still stuck.
So I want to play devil's advocate for a second and ask what the point of the proning on the flight would be, given that even when we're proning, you got to spend some time supine, right? People don't stay prone the whole time. I guess great minds think alike or fools folly together. So if you're going to have to flip somebody supine anyway, putting them on the chopper or the plane for an hour or two supine is the same damn thing that's going to happen. This is a record, I shouldn't curse. Same thing that's going to happen when, you know, in the next 8 hours later, right? Or 6 hours later when you're no longer like that. I mean, we had a lot of people who, I should say, we've experienced, hypothetically, I may have, you know, there's a possibility for patients to experience some complications from being prone, right, for too long. Not saying that I saw that in my hospital at all.
Hypothetically, yes,
hypothetical.
yes.
Yeah.
And so, you know, when you're putting them on a transport like that, and then, you know, let's say even if they are still PaO2 of, say, even getting gas, right? Their PaO2 is 50 or 47 or something, 100% FiO2. Sitting like that for the hour, as opposed to the slight gain you're going to get of what most of them maybe at best bump 10 points of milliliters of mercury for an hour, for two. I mean, we're the long-term anoxic injury is still going to be there. So I guess I just don't see the risk, as opposed to the ET tube coming out, some of the lines coming out, losing a central line. You know, to your point, it just seems like for the point of the proning is over a long period of time, and the transport's pretty short. So I don't see the argument for.
I'll give the counter. My region is massive geographically, and there are lots of little towns spread over a lot of landmass. So we have 4.5, 5 hour transport times pretty routinely over mountain passes. You can sea level a cabin only so much when you're going over a 10,000 foot mountain pass. Flying hypoxemic patients over those distances is problematic. We also have an Ecmo retrieval program, and we we'll go out and cannulate patients and bring them back when they're ECMO candidates, but there are also patients who are critical access hospitals who are not ECMO candidates. And there are those people that you all know who just don't do well on their backs. And you have to make a decision about how best to move that person over 5 hours. It's a little different than over an hour or two, tolerating, you know, SATs in the 70s when you're flying over the Cascade Mountains. So we've done some prone transports. We don't do it a ton, I would say, because, you know, our preferred approach, if someone's moving that distance, they're usually coming for an ECMO evaluation. If not, the question is, why are you moving them? Because there's not much more that we can usually offer. But we have done it in those situations where the person, for whatever reason, can't get cannulated at the outside hospital, and they just have trialed on their back and they don't do well.
Yeah, in our experience. Oh, sorry, go ahead, sir.
I'll save it. Go ahead.
Oh, I was just going to say briefly that in our experience, and yeah, I don't usually have too much of a dog in this fight. Usually this decision is made by the sending and the accepting doc. But in the cases where we have been asked to do it and or hypothetically would have done it, are cases where they just flipped the person over, like during the transfer acceptance phone call, they were like, oh, flip them over. And then they flipped them over and it got better. And now we're arriving and the people are like, what, you're going to put them back on their back? They just got better after we flipped them over. So that's the situation we run into sometimes.
And Dr. Veith, just to sort of wrap things up by coming back to a little bit more of a smaller shop setup for you, is proning something that you're recommending, or for transport times that you were talking about, like 2 and 3 hours? Is that something that you do?
No, I mean, we're proning if they're in our ICU upstairs. You know, when we've had vented COVID patients, but they have not been on maximal settings. You know, if we're approaching that, then we're definitely transferring them out. Or if there's, you know, other things going on, like we can't do dialysis, for example. So, but, you know, we have not been transporting them prone as far as I'm aware.
Thank you for that. This is I really like this question about, proning on the flight versus not, and sort of the idea of flying prone just seems even more dangerous than flying a tenuous patient in the first place. But Justin, how would you feel about taking the next question?
Yeah. Sorry, I don't know why it says my hand's raised. Too many buttons. Yeah. So off of kind of what we've already been talking about, and actually we've incidentally already touched on a lot of this. So there's this question in the chat. Let's touch on that first. Is the approach to learning curve for the next pandemic based on this one? It's a pretty big question, but I'd actually be interested to kind of work not backwards, but maybe kind of from the ground up. I'd be interested to hear your opinion on this first, Dr. Veith, just because you are in a more rural setting with maybe limited resources. So it'd kind of be interesting to see how that point differs from the kind of bigger city setting.
So I actually think that we had the upper hand because we could see what was happening in New York City. And then we literally watched it march across and up the state towards us, which gave us lots of time to request more ventilators and stockpile PPE. So we actually had this trickle of COVID for the first several months. And our true peak did not actually come until November. So we were seeing it, but we were never, quote, overwhelmed until the winter months. Which, we never ran out of PPE. We were reusing N95s and all that stuff, but we weren't having to wear garbage bags over our scrubs. I mean, we were really lucky that way. And knock on wood, we, as far as we know, have not had a single healthcare transmitted COVID case at our hospital, which has been amazing. So, I think from that aspect, I was lucky to be in an environment where we put together, our incident command team and had boots on the ground. And my CEO was walking the hallways at 10 p.m., saying, what can I do? And I'm lucky. Not every hospital was certainly like that. And then we sort of became our county center for COVID, for all of our COVID cases. So that's sort of, the good side of what happened. And I'm grateful for all of that. And moving forward, I know those conversations are now, of course, ongoing at much higher levels than mine, but PPE is, I think, always going to be one of the things, what do we have to do to make sure that doesn't happen again?
Right, that makes sense. And then Dr. Johnson, I'd be interested to kind of hear your opinion on this and also just hear, lessons for the next, hopefully not anytime soon, but next potential pandemic. And also how you've been dealing this pandemic with kind of not mass cal is the wrong word, but high COVID volume all at once. How do you decide which patient you want to treat first? And all that?
So I think the plus side, the great thing that happened in our region was our state actually got really organized, and really the whole region, the whole whammy region, as we call it, which is the 5-state region that I practice in, had a system from the beginning to allocate and distribute patients so that no one region or hospital got overwhelmed. And because of that, we were able to keep my hospital, the only level 1 trauma center, open for trauma. We were able to bring patients who needed advanced therapies to the tertiary centers because we had space for them, and keep patients who needed bread and butter critical care at the level 2-ish type hospitals in the region. And I think it was a thoughtful distribution of patients that really saved us from being severely overwhelmed. And I know that not all of the other regions in the US were lucky enough to have that. So I think that was the learning lesson of what worked well. I think what didn't work well for us, and I think probably everywhere, was we did a lot of medical practice by anecdote. And I think everywhere did. And so if I could do it all over again, and I don't ever want to, I would probably have a UK-like system where we enroll every patient that comes in the hospital in a trial, and all these questions that we're debating right now, you randomize. You don't even talk about it, don't debate, you just randomize, and you get the data and you go from there. for drug therapies, for intubation strategy, high flow versus non-invasive. I mean, there are a million questions, and we had the opportunity, we had the volume of patients early on to get answers to those questions, and we didn't take that opportunity.
Dr. Roginski, you look reflective, pensive. Do you agree or do you disagree? Have a different view on it?
No, the practice by anecdote kind of it really resonates that when I have I work in the SICU with a bunch of anesthesia critical care people. I work in the MICU with pulm critical care people. I work in the ED and I work with their flight program. And it was just wild being on 4 different email threads early on with the different approach to the intubation. And we're like this. I mean, in hindsight now, it's like, okay, bad viral pneumonia looks a lot like ARDS. We regressed to where we were before. This seems very easy, but in the beginning it didn't. And I think we got there as a system of this is at least the paradigm we should be practicing under. But I think we need a thoughtful approach or something, at least for marketing, instead of trying or we're actually following and sharing results and not just person A likes to practice this way and they're the lead of this department and person B does it this way and we're just kind of all out there doing it.
Yeah, sorry, I think there's a whole lot of ethical issues we could get into with automatic randomization, or like how do you choose who's the subject expert for anything?
Well, I'm curious how Nick Center took the Ecmo consults and then how Julie and Mike had to deal with those decisions, because we had at the time 2 Ecmo circuits and we have a 3rd now, and there was a lot going around of what's the ideal Ecmo candidate and a lot of worry about that. And I think we're lucky that we're tucked in New Hampshire and Boston took the brunt of this, and we didn't get horrifically overwhelmed and never ran out of ventilators. But I think there was a lot of ethics committee meeting and how do we partition this resource and when do we use our last circuit, that I think a lot about when it kind of parallels when I'm in the ED, I'm treating the patient in front of me, but I'm also treating the department. And this kind of made me think about when I'm wearing my ICU hat, I'm treating the patient in front of me and I'm treating the region and trying to make the best decision with the limited resource. And that I didn't expect in the ICU, I guess.
I'll take the ethical question real quick. I actually don't think it's unethical to randomize patients to 2 different versions of standard of care. We do that all the time. And many of these studies, saline versus lactated ringers or whatever, those are all waiver of informed consent because we're testing 2 different versions of standard of care. And they were getting randomized anyway. They were just getting randomized to whether I was on as the attending or the next one was. And that's the worst way to do it. Rather than some scientific approach. So I agree, if you're gonna give someone a drug or a placebo, you have to consent them. But when we're talking about different flavors of standard of care, we do that all the time.
Wonderful.
Yeah, we had one person in our group who was randomly, if you will, giving everybody vitamin C. It comes around every single time there's something and people are ill.
Dr. Sterwald, any lessons that you'd like to take into the next pandemic or thoughts?
I don't know about the next pandemic. I agree with everything that's been said. I think that the X factor really in what drove us to do things the way that we did at least a year ago was fear, not necessarily because we didn't know what to do for the patients, but because we were fearful for spreading disease, and we didn't really have that information yet, and that drove a lot of the stuff that now seems a little bit crazy. But no, next steps for me, I'm interested to demobilize from this pandemic, and like I said, it kind of changed our specialty a little bit in terms of the kinds of patients we flew and approach. So I'm particularly interested in just kind of having a reset and rethinking what PPE on the helicopter looks like, what precautions of different variety look like on the helicopter. Because wearing a mask on the helicopter, nobody did that. And thinking back, that's crazy. But that's my next step, at least.
Sorry, go ahead, Jocelyn.
Oh, no, I was just going to say, just going to hand it over to you.
Well, we're coming up on an hour. I wanted to thank everybody that's been a panelist. Sorry for the rough start, and to the attendees as well. Thanks for stopping in and listening to some folks talk about some very high level stuff that honestly it was a little bit over my head sometimes, and I just kind of did that. But any closing thoughts? I know that everyone's sort of zoomed out, I guess, at this point in the evening, but any closing thoughts from our panelists?
I actually have one from the small hospital perspective that I think it was really great to have our tertiary care centers be super supportive of our environment and the need to get our patients to these bigger centers when we had hit our maximum capabilities. And that's not always the case because of course now volumes are back up and now there's, blocked beds and we're sort of in this back to pre-pandemic diversion status. So I miss that in some ways, but I think, so often as the smaller hospital, we're stuck in this, oh my gosh, just get this patient out of my ED because I need to get them to, point X. And with the beginning of COVID and middle of COVID, there was this complete focus on, okay, how can we help you? Let's get that patient out. So, and that was great.
Yeah, I agree with what others have said. I think we've talked a lot about the stuff to get rid of and like the things that we wish we did differently, but there's a lot of good stuff and things that we learned to do better. We got to keep that. The proning is one example. Like our teams are so dialed in with proning now. We got to keep that around. Figuring out how to get families who are out of town involved in conversations around goals of care. We got really good at, telefamily meetings. And I'm really excited to have real family meetings again, but like we now have the ability to do that in an efficient way. Outreach to critical access hospitals and telecritical care was something that we dove into, and that's been, I think, helpful and a good thing all around. So I think, keeping the good stuff too, as we start to whittle away some of the stuff that we wish we didn't adopt in the first place is going to be super important.
Thank you, Dr. Johnson. All right, folks. If I don't think the attendees had anything, but I wanted to thank everybody for coming on down, and of course the panelists for your wonderful insight and perspective from each of your different areas of expertise. I hope to see you guys in person in the near future. I think holding these in person will get rid of a lot of some of the technical difficulties that we encounter, and also make it a little bit more of a back and forth. We were hoping for some crossfire like talk, but you guys are so professional and respectful. We just didn't get a lot of the cutting and anyway. So everyone have a wonderful evening. Thank you so much for coming, and we'll see you next time.